Okay. All right. Greetings, fellows. Welcome to our March, it's March, right? March Career Development webinar today. And as Kimberly mentioned, we recently had our daylight savings time, so the time has changed quite a bit, so that maybe that's why folks are running a little late. But before we begin, I wanted to make a quick introduction to our speaker, and then as before, we'll have Dr. Felicia Chow share her work. I would say for about 45 minutes, and then we will leave the remaining time for reflections and questions. And during her talk, you can also put your questions in the chat so that we have, number of questions already in place. So Dr. Felicia Chow is a neuroinfectious diseases clinician researcher who works at the crossroads of neurology, infectious diseases, and global health. It's a really interesting mix. And Dr. Chow's research is focused on predictors, patterns, and mechanisms of infection-related stroke, sex and race disparities in cerebrovascular risk in HIV infection, and treatment strategies for TB meningitis. Her current work examines intervenable drivers of sex differences in HIV-associated cerebrovascular injury and cognitive impairment, and how to identify individuals who may respond best to treatments targeting these drivers. She also leads the clinical trials investigating new regimens to improve mortality and neurologic outcomes in TB meningitis. She currently directs the UCSF Neuroinfectious Diseases Clinic, where she cares for patients with a wide range of neurological infections and regularly consults on challenging neuroinfectious diseases cases locally, statewide, and nationally, including as part of the California CNS TB Expert Network. She is a former two-time Forward GloCal Fellow, and she has championed greater diversity in research training and is committed to mentoring junior investigators in clinical research aimed at improving neurologic health worldwide. So it's a real pleasure to have Dr. Felicia Chow here with us. And I will turn the floor over to Dr. Chow.
Great, thanks so much. It's really fun to be here. Let me share my screen. Oh, actually, I think I may not be able to share. It says it's disabled participant screen sharing.
Let's see here.
Oh, I should be able to now. There we go. Okay, fantastic. All right, so I wanted to talk a little bit today about my career as a neuroglobologist, which is a term that Joe Zunt, one of my global neurology mentors, uses quite a bit, and I think is pretty fitting. So I'll start just sort of from the beginning, and I've kind of woven in bits and pieces in terms of the work that I'm currently doing, as well as some lessons learned along the way. I think we may be doing kind of more discussion and questions at the end, but if anyone has any burning question, please feel free to interrupt at any time. Okay, so I did my undergraduate training at Columbia, and I was a neuroscience major. So sort of from the very beginning, very interested in neuroscience and in the brain. And after finishing at Columbia, I took a 2-year sort of hiatus and did Teach for America, also in New York City. This in the bottom right is the school where I taught in Harlem. And unfortunately, it has since closed, but I was able to find a picture of it from back in the day. And I taught math and science, actually, during those 2 years, and had a good experience, but kind of quickly realized that I definitely didn't want to continue on as a middle school teacher. It's amazing how much sort of teaching at any grade level, and certainly, elementary school, middle school, you really have to be kind of on at all times. And that was really tiring and something that I kind of quickly learned was not for me. And so from there, I went to medical school at Hopkins and kind of quickly found global health. And it was in my first summer during medical school, so the summer after my first year, that I had the opportunity to spend some time in Lima, Peru. And this was with Bob Gilman and the group that he works with and leads in Lima. And it was just a summer experience. So I was really fortunate to be able to go to Lima for the summer. And not only did I have this, great fortune to be able to have this experience, but I actually was able to participate in a research study pretty much from start to finish, which is pretty rare over such a short period of time. But it was another sort of lucky thing that happened. And this particular study was related to tuberculosis. And I worked with Dave Moore, who was my mentor on this study, and he's a TB expert. And it was a really fun and engaging project. And basically what we were doing was testing out this string test. And it basically was something we were using in a pediatric population, and we were testing sort of the tolerability and acceptability of having kids of all ages, as young as 3 years and older, essentially swallow this string capsule. And we embedded it in Jello. And we spent a lot of time sort of prototyping and kind of, put it in Jello, tried it in honey, a lot of different ways to get kids to swallow this. And basically they swallow it, and there's an end of the string capsule that gets stuck on the side of their mouth, and we taped it down, and it stays down for a number of hours. And the idea is to be able to then actually pull the string up when the testing time is over, and then test the end of the capsule for tuberculosis, basically. So, you're getting gastric samples from a population of people at risk for TB, meaning kids in this case, who have, for a number of different reasons, difficulty producing a sputum sample, and also just lower yield in terms of diagnostic testing from sputum samples. And so as a result, gastric samples using this string test can be really helpful. So it was a really fun experience for a number of reasons. And like I said, it's really uncommon to be able to take something sort of from start to finish in such a short period of time. But we were able to do that, and we published the study in terms of what we found. It was amazingly well tolerated, and I think when I was here, at the time, something that some of the people that I worked with told me, and it absolutely was true, was that kind of be careful, because the very first experience that you have, kind of the first thing that you dive into, may be something that shapes what you do for the rest of your career. And so I think, one of the first, sort of lessons or things to keep in mind is, show up and really learn as much as you can from the get-go, because you never know sort of what it is that you may take from that experience and learn from that experience. And as I said, it may very well kind of shape what you do for the rest of your career. And that's very much been the case for me. I didn't necessarily know it at the time that I was working on this tuberculosis study, but I have very much continued in terms of my interest in tuberculosis. And now a large part of what I do is focused still on tuberculosis. And I'm working on a number of tuberculous meningitis clinical trials now as a neurologist. Now I'm focused on tuberculosis that affects the brain and the nervous system, but it's an area of focus that really has become one of my primary passions. Tuberculous meningitis, for those of you who aren't familiar with the disease, is a really devastating clinical disease. So this is two examples, two different cases. Both of these cases are cases actually that I saw here in San Francisco and that we cared for here in San Francisco. But of course, tuberculous meningitis is a disease that has really high incidence, in low and middle income countries. And we see a lot less of it actually here in the United States. But both of these cases are cases here in the US. The top case was a 17-month-old boy who came in with fever, emesis, seizures. He was gene expert positive, so that's the test that we use, or one of the tests that we use to make the diagnosis of tuberculosis, off of a trach aspirate. So he had a breathing tube, he was intubated, and we were able to get the sample off the breathing tube. And that same sample was also culture positive for tuberculosis. And it ended up that the mom was actually the source case, and she had active pulmonary tuberculosis and was incredibly infectious and didn't know it, and had infected her young son. And then this bottom case is a young 22-year-old woman who'd come from Mexico not too long before she became sick. And she presented with fever, shortness of breath, paresthesias, initially was diagnosed with COVID. So she had COVID, and then sort of soon after that, we realized that there was something else going on, and she was diagnosed with both pulmonary TB and then also TB affecting the brain. And I think you can appreciate sort of all of this white material here on this brain MRI is all TB infection. So really profound degree or burden of tuberculosis that she had affecting her brain. So in particular, I often work with populations of people living with HIV who have TB meningitis, and that particular population we know has worse outcomes compared with people without HIV. And it's really amazing to me the mortality rates in people living with HIV who have TB meningitis can be as high as over 50%. So over 50% of people with HIV who develop TB affecting the brain can die. And then in addition to that, of the people who survive, there's not a clear difference between people with and without HIV, but another about half of people who survive can have some form of pretty serious neurologic disability. And we've done studies both in California and then also studies in other parts of the United States that have really confirmed this, that people with HIV are both at higher risk of TB and TB meningitis, and they also have worse outcomes as well. And so, because of this, there's a lot of interest in terms of improving how we treat TB meningitis. Our regimens that we use for the treatment of tuberculosis really are suboptimal in terms of how effective they are for TB affecting the brain. And so one of the studies that we are working on currently is in collaboration with a group in Masaka, Uganda. And it is basically looking at the addition of a pretty common antibiotic that is now in use for pulmonary tuberculosis, especially for drug-resistant pulmonary tuberculosis. But we know that this particular medication called linezolid also gets into the brain well. It's able to penetrate the blood-brain barrier. And as a result, we are studying it in this particular trial in Uganda to see whether or not it may improve outcomes in people with tuberculous meningitis. So this is our study team here working with a patient, doing a lumbar puncture actually for a patient. And this is the ALTER trial that is currently in process. And the objective of the trial is to investigate cerebral spinal fluid and plasma pharmacokinetics and safety and tolerability of adding linezolid for the first couple of weeks of treatment for TB meningitis in people living with HIV. This particular trial is a phase 2 randomized open label trial. It's taking place in Masaka, Uganda, in southwestern Uganda. It's a 1-to-1 randomization, and we're randomizing people to either high or standard dose rifampin, and then also with or without linezolid. We have screened a pretty large number of people. There's a pretty high screening to enrollment ratio. We've pre-screened over 150 at this point participants. This isn't a fully up-to-date figure I'm showing here, but we've pre-screened over 150 participants, and we've now randomized, I believe, about 33 into the trial. From there, so that's a little sort of side note in terms of some of the work that we're doing currently in TB meningitis. I'll jump back now, back in time, back to medical school at Hopkins. I mentioned that I'd gone to Lima, Peru after my first year of medical school. And then between my third and fourth years of medical school was when I was a Fogarty Fellow. I did my sort of first Fogarty Fellowship during that time and went back to Lima, Peru. So, based on my experience in that first summer, I was really anxious to get back to Peru and to really have a longer period of time to develop, more of a research study in sort of infectious diseases. And by this point, given my interest in neuroscience, I was still deciding in terms of what I wanted to do for residency after medical school, but was really thinking very seriously about neurology versus doing internal medicine and infectious diseases. So I ended up working with Joe Zunt, who's been sort of a lifelong mentor of mine in global health. And he's at the University of Washington, went back to Lima, Peru, and had the opportunity to work in a disease called cysticercosis, which is a parasite infection of the brain. My project was using transcranial Doppler ultrasound to detect cerebrovascular abnormalities in patients with subarachnoid cysticercosis. I had a number of mentors, very fortunate to work with Joe Zunt, of course, and then Sylvia Montano and Hugo Garcia, and worked in a number of different places, but my primary project was at Hospital Mogrovejo, which is what you see here in this upper left corner. And then I think actually most of these photos are from Mogrovejo, and worked with a fantastic team of individuals there, including Irma Quispe and others who were neurologists and stroke neurologists who took care of course, these patients who were coming in with strokes, some of whom had evidence of this particular infection that we were interested in. And it was really after that experience that I returned to the United States and kind of solidified not only my interest in global health, but really specifically in pursuing and continuing to pursue global neurology. And I kind of made the decision after that one-year experience that I wanted to apply in neurology residency and sort of continue on in my career as a neurologist and really as a global neurologist as well. So from there, I entered residency at Partners, which at the time is MGH and Brigham and Women's Hospital. So that's where I did my neurology residency. And I was really lucky that as a resident, I had a couple of opportunities to continue to pursue global health. I did a global health elective in Kisumu, Kenya, during residency with Anna Claire Meyer, who was at the time at UCSF. And again, this was during residency. And oh no, I didn't change this. So I didn't do the same project in Kenya, but rather this was a project that was looking at the prevalence and looking at the diagnosis of cognitive impairment in people living with HIV in Kisumu, Kenya. A number of people that I worked with, including Anna Claire Meyer, Judith Kwasa, who's now a neurologist in Kenya. At the time, she hadn't trained yet as a neurologist. And then Deanna Saylor, at the time known as Deanna Chetamai, before she was married. And we worked at FACES, the UCSF Family AIDS Care and Education Services at Kisumu. So this was a really short experience. I think I spent about 6 weeks there. And so during that time, I was fortunate because, I didn't have in such a short time the ability to sort of start my own project, but this was already an existing project that I was able to kind of join onto with the existing research team. And I was able to help out with my sort of new neurology skills as a neurology resident. I was able to do neurologic exams and do some of the neurocognitive testing of participants that were involved in the study. You can see in this picture here, these tents were actually our research sort of rooms where we would have participants in these tents doing the neuro exams and doing the different testing that we were performing as part of the study. And then in my last year residency, I had one more chance for another global health experience. Again, a short experience. You can imagine during residency, being able to put together enough time to travel is tough. And being able to find a project where you can be useful in such a short period of time is also a challenge. But I was able to work with a team in Guangzhou, China, and they were doing a community-based stroke care project in a rural setting. And I worked with Weiping Liao and En Xu, and this was through the Guangzhou Medical College Institute of Neurosciences. So again, a short project, about 6 weeks or so that I was there, and able to sort of insert myself into the project team with their sort of welcome reception. And it was sort of the same thing. I was able to use my skills as a neurology resident to be able to do neurologic exams and to be able to do some chart review for this particular study that was really looking at the approach to stroke care, and specifically acute stroke care, and thinking about TPA, and really the reason why the hospital was actually not using TPA, which is a treatment that's used for acute stroke. So if people come in within a certain number of hours, you can administer this clot-busting drug. But they were finding that very few patients were coming in a timely fashion to be able to take advantage of the drug. And so a lot of this was focused on why that was and sort of what could be done to change that. Okay. So that brings us up to fellowship. So I then became a fellow at UCSF, where I am now, here in San Francisco. And it was during my fellowship that I then became a second-time Fogarty Fellow, or now GloCal Fellow. And I really sort of leveraged my interest in continuing to do work in China and continuing to work specifically really in stroke, but I was able to merge sort of my interests in both infectious diseases and stroke and neurology, and did a project focused on stroke in HIV, and really specifically on stroke and the detection and diagnosis of being at risk for stroke in people living with HIV in China. And we once again use transcranial Doppler, which is a non-invasive imaging modality that's pretty easy to implement. And we use that to evaluate vasoreactivity and to evaluate stroke risk in people living with HIV. And this was all in Beijing, China. And I worked with Kaisheng Li and Huanling Wang, and was able to put this study into place during this year-long period of time. We were able to finish the study during that period with the help of a huge team of people, including the nurses that you see here, who were really integral in terms of participant recruitment and enrollment. And then our TCD ultrasound technologist, who was trained in this particular study that we were doing, and this particular type of ultrasound study. And you can see her here with one of our participants. And so, the work that we did during the GloCal Fellowship really became sort of the first study in a series of studies that we did. And also the work during the GloCal Fellowship, we were able to leverage and get NIH funding to continue. And so this is the work that we did during the GloCal Fellowship, basically We studied 75 people with HIV, and this part of the study was just in Beijing. They all had HIV. They were all treated and virologically suppressed, so their HIV was very well controlled. And we did this specific transcranial Doppler ultrasound study to look at vasoreactivity, so how well the blood vessels react to changes in carbon dioxide based just on breath holding. So basically at baseline, you can see when you're doing the transcranial Doppler ultrasound, this waveform that shows how the blood is flowing through the blood vessel that you're studying. And basically, when you have someone hold their breath, then they become hypercapnic. So when you have someone hold their breath, their CO2 levels rise, and that actually causes vasodilatation of the blood vessels. And you can actually see an increase in the flow velocity of blood as it's going through the different blood vessels. And so I think you can appreciate here, there's an increase in the blood flow velocity, and the waveform gets higher. And then when you have someone hyperventilate, they're blowing off their CO2, they become hypocapnic, and their blood vessels actually constrict, and then the blood vessel blood flow through the blood vessel actually decreases. And I think you can appreciate that here. So this is a measure of how well the blood vessels are able to react to changes in CO2. And that vasoreactivity, we call it, is actually very well correlated with stroke risk. And so the worse your vasoreactivity, the higher your risk of developing different types of strokes. And so we were doing this in a population of patients with HIV. And one of the really unique things about working in Beijing with this population is that there actually are very few antiretroviral therapies that are available in China, because all of the medications come through a government program. And so for the most part, when we were doing this study, almost every participant was on a very small number of medications. And that's in contrast to the United States, where for a number of different reasons, there's just a much wider variety of medications that patients are either currently on or have previously been on. Whereas with this population, again, it was just a very small number of medications. And so that made it easier for us to try to tease apart the relationship between some of these medications and cerebrovascular function in these patients. And ultimately, what we were able to really kind of tell based on the analysis was that there were certain medications that were associated with worse cerebrovascular function and higher stroke risk in people with HIV. So we know that in people with HIV, not only can HIV increase cardiovascular risk and stroke risk, but also the treatments that we give for HIV can also affect stroke risk and can also cause a number of different complications. And it turns out that one of these medications that's in the protease inhibitor family, lopinavir/ritonavir, was the medication that we found that there was a significant lower cerebrovascular function, meaning higher stroke risk in people who were on that particular medication. And in fact, since we've done this study, most patients who are on this particular medication have actually been switched to a different medication. And then as part of this, we actually were able to take advantage of some additional testing that participants in our study had as part of a different study, in which they had some very basic screening cognitive testing, something called the MoCA. This is a basic sort of bedside in the clinic screen that can be done to look at cognitive function. So we were able to look at some of our testing in terms of the transcranial Doppler testing and see whether or not there was any correlation with cognitive function on the MoCA done as part of a different study. And we did find that there was a significant correlation between basically better function cerebrovascularly was associated with better cognitive function on the MoCA. And we were able to publish this study. And then that was basically the start of our next collaboration, in which we were able to leverage what we did in GloCal and turn that into basically an R21 grant, an NIH R21 grant, to really kind of dive into this deeper. And so I think sort of the next lesson kind of learned for myself really is, I think many of you have probably gotten the advice that it's good to kind of focus yourself, especially earlier on in your career, so you don't spread yourself too thin. And you've probably heard, from others that it's important to learn how to say no to opportunities that might not necessarily fit with what you're doing and might not necessarily advance your career. But I think at the same time, it's okay to have a few irons in the fire, and that's certainly something that I've always done sort of throughout my career. You don't want to spread yourself too thin, but I think it's okay to have a couple of things, maybe 2, maybe 3 at the most, that you're working on, and sometimes those things may be completely different, and they may not all be in the same area of focus. And so you can see that this work that I've done in cerebrovascular disease and HIV is really quite different than the work that I've done in TB meningitis. They're both in populations of people living with HIV. They're both sort of neurologic issues, but that's really where the similarities stop, to be honest, and they're quite different. And I have really enjoyed having sort of 2 areas of focus and being able to develop both areas of focus. And I think it's something that's really worked for me. I think that when I was in China, kind of working on the GloCal project, prior to going to China and after being in China, and a little bit while I was in China as well, I had some additional work that I was doing in kind of cerebrovascular risk and HIV, but in different populations. So I was doing work in a completely different cohort that's based here in the United States in the AIDS clinical trials group. And we were looking at cardiovascular risk and its impact on cognitive function. And that's what this study is here. And it was through this study that we started to note that there were some sex differences in terms of cardiovascular risk in HIV, in which basically people with HIV, it seemed like women really had a greater negative effect of cardiovascular risk on cognitive function. So in this particular study, women are on the left, men on the right. And we found there were a number of cardiovascular risk factors that impacted cognitive function in women. So diabetes, for example, was a risk factor. And then being more physically active or having higher HDL were protective against cognitive dysfunction. Whereas in men, we didn't find that any of the cardiovascular risk factors had an impact on cognitive function. And we also found sort of similar findings in the same cohort where, again, having higher cardiovascular risk really had an impact on cognitive function in women, but not in men in this group. And so the reason why I bring that up is because as we kind of leveraged our GloCal work, we were able to get Fogarty funding with this R21 to continue the work that we were doing in this particular cohort. And this time we had a cohort. Oh, sorry, I don't know why it's kind of advancing on its own. I'm not sure why that's happening. But anyway, so we, in this R21 study, we were working with the same cohort in Beijing, and then we also expanded to a different site in southern China. So we had 2 different sites that we were working with, and we did the same transcranial Doppler test, but this time we did much more in-depth cognitive function testing. And as part of that, based on what we were learning in some of these other cohorts that we were doing work on, we decided to also look at whether or not there were differences between women and men in the group, and found, very similarly to what we found in some of the other cohorts, that there was sort of this relationship for women in terms of cerebrovascular risk and cognitive function. We found it in terms of global cognitive function, and then also in terms of other specific cognitive domains, that having worse cerebrovascular function led to worse cognitive function for women, but not for men. And this was a very interesting finding that, again, kind of corroborated what we were seeing in some of our US-based cohorts. And from there, we were able to leverage that and to take those findings, which served as sort of our preliminary findings for a current R01 study that we're doing, in which we're really trying to understand what some of the mechanisms are that are driving sex differences in cognitive function and in cerebrovascular risk in people living with HIV. So I think all of the work that we did in GloCal kind of contributed to this Fogarty R21 grant, which then kind of served as preliminary data for our current R01. So we're really excited to be able to build on the work that we did in China to be able to learn more about this particular finding and to try and figure out kind of what's driving it. So I want to just say a little bit about mentorship. It really is a team effort. That's probably something else also that you all are hearing about and learning about. And I think it's particularly true in global health. This is kind of not all, but many of the people, who have served as my mentors, who have mentored me kind of throughout the years. And I think whenever I think about mentorship, I think it's really helpful to think about sort of the fact that, you may not find one person who's able to mentor you in all the different areas that are necessary for you to be successful, but that it is helpful to have different mentors who are, working together to help, in terms of your mentoring team, and they may really address very different things, So I think it's nice, of course, to have a primary mentor, sort of one person that's helping to sort of coordinate your mentorship and oversee everything. But I really think about, having multiple types of mentors. So I think in addition to the primary mentor, it's really helpful to think about kind of a content mentor and a methods mentor. So someone who's an expert in the area that you're working in, both in terms of kind of the content area and then also the different methods that you're using. And so I've had a number of content and methods mentors through the years, including specific stroke mentors like Steve Fesky, a specific mentor for the transcranial Doppler ultrasound, Farzaneh Sarand, mentors who've really been experts in sex differences in stroke like Cheryl Bushnell, and then methods mentors in sort of the biostatistics like Peter Becchetti, excuse me. And then in addition to that, having kind of global health mentors, so mentors who really know what it's like to develop a career and to build a career in global health. And I've had a number of people who've really served in that role, and I think Joe Zunt is definitely one of them. Career mentors who kind of offer advice along the way. And then peer mentors, I think, are really also quite helpful. I've found that some of the most helpful mentors to me have been people who are just a few years ahead of me in training, who I've been able to turn to for help with a lot of the questions that come up along the way in terms of, applying for funding, in terms of how to find mentors, in terms of, writing papers, all of those things. I have found peer mentors really are some of the most helpful in terms of some of those questions. I think, another thing in terms of global health that, is a recurring theme, again, something that you've also probably heard a lot about, is, it's really all about the partnerships and collaborations that you develop. And I think that, this has been absolutely true in terms of the work that I've done. So, this is the teams that I've worked with in Uganda on our TB meningitis trial. They've been really integral. I mean, without them, of course, none of the work that we've done would be possible. And what I would say about that is it's really helpful also to not just, identify a team of partners that you're working with, but to really develop the study with the partners, so that you can be sure, of course, that what you're doing is relevant, to the people that you're working with and to the patients, or whoever it is that the study is that you're, kind of working with, that it's relevant to them. And then I think on top of that, it's really helpful to have one or two individuals that you're working with in country who are really your equals, and are really as invested in your work as you are. And for me, in Uganda, that's been Freddie Kabengo, who's shown here in pink. And he's really been my sort of partner in crime in all of the work that we've done in Masaka. And again, without him and without, the rest of the team, none of what we're doing with our trial would have been possible. And the same in terms of the study team in China, in Beijing and Shenzhen. A number of people who've really been integral to making it all possible. Taisheng Li has been a primary mentor of mine, but I think Huanling Wang has been sort of the person on the ground who's really been a key partner. Without her and without sort of her investment in the study and really her dedication to making it happen, none of what we've been doing would have been possible, for sure. And so I think investing the time in building relationships is really critical. I think it takes a lot of time to build these partnerships, but I think that time is well spent in terms of laying that groundwork, really thinking about bidirectional partnerships, of course. I think it's really helpful to develop kind of very specific and concrete skills that make you useful, in the setting where you're working. And I think I've mentioned a few times already that as a neurologist, for me, being able to use my neurology skills and do a neuro exam, do neuropsych testing has been really important in terms of the work that we've done. And in addition to that, of course, thinking about not just what you bring, but really taking time to listen and to remember that, your partners also bring as much to the table. And thinking about that and thinking about, what is it that you can learn, obviously, from your partners in order for your partnership and collaboration to be successful. I think always thinking about equity and fairness, and this can be something as concrete as authorship and recognition. I think, when you're starting a global health partnership and when you're starting a study, it's important to talk about authorship at the very beginning of your collaboration, and to make sure that the people that you're working with are recognized, and that the people that you're working with in country are able to participate in terms of being authors on your publications, and really to think about that, I think, more as just not just that they're kind of middle authors, because it's nice, of course, to be included in a paper as a middle author, but to be able to provide opportunities so people have the ability to take on more and to have the opportunity to play a role in which they're able to be either the first author or the last author on a paper, I think is also really important, and probably something you'll think more about, as your career develops. And really to take every opportunity to promote your colleagues and collaborators, because it's absolutely true that their success really is beneficial to the whole team, including to yourself. And I'll just say really quickly, I think it's never too early to start thinking about sustainability for your projects. Obviously, you want to be working on projects and thinking about how your work can continue on, whether you're there or not. And I think it's never too early to think about what your succession plan is. So if you're not there, kind of who's going to take over for you, who's going to continue the study or continue the work that you're doing, and really thinking, several steps ahead. You've taken so much time to develop a partnership, to develop a study, how can you build on that hard work and build on your accomplishments? And, what are you going to do to kind of continue that collaboration in the future? I think I've talked a lot about I think luck as one thing. I think at the beginning I mentioned that a few times, just in terms of being lucky enough to kind of be a part of a team. I think creativity, skill, all of those things are really critical in terms of success. But I would also say, persistence is probably as important, if not more important, than some of these things. And I think that really is true in terms of thinking about funding. And this has sort of been my funding trajectory in terms of kind of where and at what points during my career I have been able to be fortunate enough to have funding to support me, initially with a CFAR, Center for AIDS Research project that really helped me to develop skills in transcranial Doppler ultrasound, which I then took and kind of used in my GloCal fellowship, as I mentioned. And then from there, I had a UCSF KL2, which is an institutional K award, and then also a foundation fellowship. And then from there, actually, the R21, as I mentioned before in China, I actually had funded before a K23 award through the NIH. And then another Fogarty R21 to support the TB meningitis work that we're doing. And then from there, as I mentioned, the NINDS R01 work that really built off of a lot of this prior work in China. And so, that's sort of the trajectory. But I think when you see that, you don't see all the other sort of applications and all the other grant submissions that weren't initially funded or weren't funded at all. So, I think I'm just highlighting here that, all of these were resubmissions. So first time not funded and required, of course, that they be resubmitted. And then a bunch of other grants that I'll just show here, all of which were not funded, and so I think that, for every success you have, just know that all of us have a bunch of failures that come before and will come after your successes. And I think that it's really important to just keep going. I feel like every time we get our comments back on a grant, you can spend a little bit of time kind of wallowing in the comments and the fact that you weren't funded, and it's painful every time. But I give myself a little bit of time to sort of breathe the grant, and then after that you kind of have to learn from it, and then decide what are your next steps. And I think being persistent and sticking with it is really the only way that you can get past those failures and continue on to your successes. And so in terms of funding opportunities, I think constantly thinking about kind of what funding is available, what funding is kind of relevant to the work that you're doing, I think is critical in terms of, being successful. I think most institutions have some funding opportunities. At UCSF, it's the RAP program, the resource allocation program. They are usually smaller, often kind of targeted, pilot grants. They tend to be less competitive, although they can also be quite competitive. I had found some statistics on the UCSF RAP website where 43% of the grants submitted in the last round were funded, so definitely a little bit less competitive. And they had 122 applications reviewed, 53 were awarded. So it's certainly something to look into. If you're at UCSF, absolutely look into the RAP Awards. If you're at a different institution, see sort of what equivalent type of institutional funding might be available. Thinking about foundation funding, the Gates Foundation, of course, and then, whatever is your specialty or subspecialty area. So for me, of course, it's all neurology. So American Academy of Neurology, and then also infectious diseases funding. And then, of course, there's NIH funding and other government funding. Thinking about career development awards, I'm happy to talk with anyone at any point about sort of, thinking about applying for these awards and how to prepare. And then also the R awards, in addition to USAID, CDC, Department of Defense. And then one thing I always like to put a plug in for, because I think it tends to be forgotten, is the NIH loan repayment plan. It doesn't fund any of your research, but it helps to pay off a really considerable chunk of loans that you may have. For me, of course, it was medical school loans, and it's a really amazing program. So you may already be eligible, sort of during your fellowship time is when I applied for it. It paid off a huge amount of my loan. So it's something to not forget and to definitely look into to see if you're eligible. And so I know I just have, I think, actually, I think that I probably should stop here because I think we're already at almost 9 or 51 past the hour. So I'll just leave this here in terms of, I wanted to provide a little bit of practical advice. And so this is just about like kind of your approach to writing up results and sort of, how to approach like writing a manuscript. And so I think you guys will have my slides, so you can just take a look at this yourself. I just have a couple of tips in terms of writing up results, and then some sort of examples from just a paper of mine in terms of how to face the discussion, which I think is probably the most difficult part of writing up a paper. So I'll stop there. I'll stop sharing, and happy to take any questions that there might be.
Yeah, Dr. Felicia Chow, thank you for sharing such an impressive career trajectory. And yeah, it's really inspirational to to kind of see, your expertise in, neurology and how you applied that to many different situations and many different countries. So I thought it was really remarkable. So yeah, it's a time for us to ask questions. So feel free to unmute or use the chat function to ask away.
Hello, Dr. Chow. Thank you so much for this really wonderful presentation. I was smiling to myself because I saw a few familiar names. I'm currently in Tumbes, Peru, and I'm working with some of the team that Hugo Garcia has built here. And while I'm not doing anything neurologic, it was wonderful to see how everything is related, which I think is like something I'm learning about the research world, is that everything seems a lot smaller as you start to get to know people.
Oh, it's so true. Yeah.
One of the questions I had for you, I think, you were mentioning a lot community partners and building stronger relationships with community partners so that the work is both sustainable and meaningful. I'm curious, like, if you can describe like maybe some of the challenges you might have encountered building those meaningful relationships, and briefly like kind of give us some of these useful pro tips on navigating some of those complexities so that we can continue to build those sustainable relationships.
Yeah, that's such a great question. I mean, I think that probably what I have found is that I think in particular, if you are based, in the location where you're doing your work and you're there for an extended period of time, that's probably one of the biggest strengths of being able to, establish partnerships is being there, on the ground, and and not just for a short stint, but for a more extended period of time. So that's one of the amazing things, of course, about the GloCal Fellowship, is that it provides you with that opportunity, because I think that once you're no longer, so of course there's some people who do global health work and are and they continue to be based in country, and so that it's one potential model. But I think that if you're not, and if you are then sort of mostly in the US or mostly somewhere else, and you're kind of traveling back and forth, I think then it becomes one of the biggest challenges is that, it's hard to sort of continue and sustain those relationships when you aren't there, on a day-to-day basis, because so much of developing those partnerships is really being present and, being there, and, kind of face-to-face time, et cetera. And so I think that's where it comes in, that it's important to really have kind of a person, or maybe one or two people who I think are able to kind of partner with you and really be able to also kind of be the liaison with the community partner that you're working with, or whatever the group is that you're working with. So being able to really kind of identify that person and establish a relationship with that person, I think is really important. So I think that that's probably one thing. And then I think the other thing is, I think trying to find ways to see what is it that the community partner really finds useful and will find helpful for the work that they're doing, or whatever their interests are, et cetera. Because if the project you're doing is something, of course, that they're invested in, and something that they feel will benefit the patients that they work with, or the clients they work with, or whoever it is, I think that also is really critical, because I think once they're invested in the work, then you have their buy-in, and that's something that will really help to drive whatever it is you're doing forward. And so I think that comes back to making sure that whatever you develop kind of in collaboration with your community partners. And I think I have been amazed at how much time it takes, to develop these partnerships. They're not something that happen overnight, and they're not even something that happen over, months, or, even over a year. I think the strongest partnerships really take time to develop, And I think the more that you invest that time and really show that you are invested and that you're really committed to the partnership, it really helps the partnership to grow even more. So yeah, but I agree with you. I think it's the most critical part of this work, but it's also some of the most challenging in terms of how to develop those partnerships.
Thank you so much. That was actually incredibly helpful, especially looking down the line of going to residency and knowing that there will be time when I cannot make time to be in person. And that tip about finding like one or two people that can help be that link, especially has been like very helpful. Thank you so much.
Yeah, absolutely.
Great. Thank you. So any other questions for Dr. Chow?
Hey, this is a UCSF specific question. Sorry, I don't have my video on. I've poor internet, but I'm Nathan. I'm a general surgery resident at UCSF. And I saw that you mentioned the RAP award, but when I was looking into this, it's relatively limited in its global scope. And I was wondering how you would use the RAP award funding mechanism to fund global work.
Oh yeah, that's a great point. So it can vary quite a bit in terms of kind of the specific awards that are offered. And like you said, each of the awards, because it's a bunch of different like funders who are kind of supporting the different awards. So it's, different groups, et cetera. And so you're right. Some have restrictions in terms of where the funding can be used, but not all of them do. So it really depends. And so the RAP award that I received actually was for work that ultimately I applied to some of my global health projects. But you're right, the specific award that I used actually wasn't for a global health project. But I now review for the RAP award mechanism. I'm one of the grant reviewers. And I know that some of the awards will allow global health work, but not all of them. So you do have to just look and see specifically, which ones will allow for it and which ones will not. I don't know if I'm not sure, Kimberly, if you're involved at all with the RAP stuff or if you have any further knowledge in terms of that mechanism. But yeah, it's a good point, Nathan. Not all of the awards will allow it.
Yeah, I don't know much about that. So you're much more knowledgeable than I am. Thank you.
Well, so we're almost at the hour. This has been such a wonderful session, and I'm sure this slide deck will be available. So fellows, you can look at the last couple of slides about the manuscript writing tips, and also the recording will be available for future viewing. So again, thank you so much for your generosity and taking the time to talk to us. Appreciate it.
Thank you all. Yeah, it was great. Thanks so much, everyone. Take care.
All right.
Thank you.
All right, Kimberly. Do you have any announcements for the fellows?
Please submit your progress reports. That's the only one. I'm working on our annual report.
Very
anyway.
important.
Yes.
Yeah, you gotta highlight your progress and all the wonderful things that you have accomplished so far. So
that's right.
all right,
That's
great.
the only one.
All right, thank
Have
you
a
all.
good day, evening, everyone.